my name is Emma Robbins, and today I'm speaking on behalf of my co-authors in the Cancer Screening Prevention Research Group at Imperial College London, as well as those at Queen Mary University, the University of Edinburgh, Public Health England Screening, and Kaiser Permanente in Northern California. One of our main research interests focuses on post-polypectomy surveillance, which involves surveillance by colonoscopy following the removal of colorectal polyps. And our aim is to identify who needs and benefits from surveillance the most. And this is important because surveillance colonoscopy is costly, burdensome on endoscopy services, and carries a small risk of complications for patients. We recently published an article in Endoscopy titled Heterogeneity in Colorectal Cancer Incidence Among People Recommended 3-Yearly Surveillance Post-Polypectomy, a validation study. And we performed this study in light of the findings from one of our previous studies published in Lancet Oncology in 2017. This previous study examined long-term colorectal cancer incidence among patients recommended 3-yearly surveillance after removal of adenomas in accordance with the 2002 UK surveillance guidelines. We found that 2/3 of patients remained at increased risk of colorectal cancer after adenoma removal, and these patients were those with an incomplete colonoscopy, poor bowel preparation, an adenoma measuring 20 mm or more in diameter, an adenoma with high-grade dysplasia, or proximal polyps at baseline. And these patients derived great benefit from attending surveillance. In contrast, the remaining 1/3 of patients had a lower risk of colorectal cancer than the general population after adenoma removal, and we suggested that these patients could forgo surveillance. This 2017 paper was the first to identify heterogeneity in colorectal cancer risk among individuals recommended 3-yearly surveillance. And so we wanted to explore whether these findings apply in a completely different patient population. While our previous study included patients referred to hospital for colonoscopy, the present study included individuals undergoing colorectal cancer screening. So for the present study, we pooled 3 datasets of individuals participating in routine colorectal cancer screening in the UK and US, and we examined colorectal cancer incidence among approximately 2,300 individuals who were recommended 3-yearly surveillance at baseline colonoscopy. After a median follow-up of 12 years, we found that the same risk factors identified in our previous study discriminated a high-risk subgroup, accounting for 45% of the cohort, from a lower-risk subgroup, accounting for the remaining 55%, and that surveillance only clearly benefited the higher-risk subgroup. These findings are important because they add weight to the idea that people recommended 3-yearly surveillance are a heterogeneous group with variable colorectal cancer risk, and that some may not require surveillance. Our findings show that incomplete colonoscopies, poor bowel preparation, large adenomas, adenomas with high-grade dysplasia, and proximal polyps are important risk factors for colorectal cancer, and that these factors could be used to identify individuals who need surveillance the most. In line with this, the recently updated UK surveillance guidelines emphasise the need for a high-quality baseline colonoscopy and include large adenomas and adenomas with high-grade dysplasia in the classification of high-risk patients who are recommended surveillance. So future studies should examine colorectal cancer incidence among patients classified as high risk according to these new guidelines, and should aim to more clearly elucidate the association between baseline proximal polyps and future colorectal cancer risk. Thank you very much for listening, and if you would like to find out more about our research on colorectal cancer screening and surveillance, please follow us on Twitter. Our handle is @CSPRG_Imperial.